So good afternoon. I'm Marian Mulkey. I'm the director of the California Healthcare Foundation's Health Reform and Public Programs Initiative, where we work to advance the effective implementation of health reform within the context of California's healthcare finance and delivery system. I want to thank you all for joining us today. It's a full room and looks like a great crowd, and we've really got a good discussion planned today, so it's wonderful to see you all. We also have a number of people joining us by phone, listening in, and the session's being videotaped, as those of you who are here in person can see. We expect the video of the event to be available on our website within just a few days, and it will stay there indefinitely. So judge your comments accordingly. Just a couple of logistic matters. If you all could turn off your cell phones. There was a timely ring in the background there. Again, if you can move in together as much as you can, it'll help us get everybody seated. Just a couple of quick notes on the packet of materials that you've got. There's an executive summary in the packet. The full report is actually about 45 pages long. It is now available on the chcf.org homepage. We thought we would not assume that everybody wanted all those pieces of paper, but we would encourage you to look at it because it really includes a lot of detail and specificity that isn't all in the executive summary. We also have, as usual at a CHCF event, a brightly colored evaluation form. We really do appreciate it if you fill this out and turn it in. It does inform our thinking, and in this case, because we're sort of at the beginning point of a body of work on this topic, I personally would love to have your thoughts about what an appropriate role and set of next steps would be for this work. So please feel free to offer those comments this way or directly to me by email or whatever way is easiest for you. In terms of the agenda, Deborah's going to start after I make these few remarks. Deborah's going to start with a presentation. We'll offer a short opportunity for questions of clarification after that. We have 4 distinguished reactors who will be then speaking briefly, and then we expect to have time at the end of the session for open questions and answers on, for all the speakers and on the range of topics related to our subject today. And so, turning now to our subject, while perhaps not the most headline-grabbing aspect of the Affordable Care Act, the oversight of health insurance is really at the very heart of some of the promise of the Affordable Care Act to increase coverage and to protect and assure consumers of the quality of the products that they're given. And those are goals that we at CHCF are really committed to as well. Better access to coverage, greater accountability and transparency with respect to what's being bought and sold, and a first-rate consumer experience in getting and using health insurance. So these are topics that matter to us, and I think by virtue of your attendance to everybody in this room as well. The oversight of health insurance in California is something that, again, we at CHCF, as well as the authors of this report, have been observing and working on for more than a decade. And California's split approach between the Department of Managed Health Care and the Department of Insurance is something that we all have learned quite a bit about. And we certainly understand that it has a strong basis in history and state law that we understand and respect. At the same time, having those 2 regulators is confusing at times to consumers, and it adds administrative and cost burdens to health insurers, insurance carriers, as well as to government agencies and insurers. So, against that backdrop, the history of regulation in this state, which is pretty well known, I think, to most of you in this room, here's the Affordable Care Act, which layers on additional demands and expectations of states with respect to the oversight of health insurance. In some cases, the new law creates new federal floors or requirements that are pretty straightforward about what can be sold and how. But in other cases, it delegates critical tasks to states. It's our belief that without a well-informed and intentional process, there's considerable risk that the complexity of the federal law layered on to our existing regulatory environment could interfere with consumers' experience and really keep the goals of the federal law from being fully achieved. So, understanding the opportunities and the risks of this new environment that we're entering, some time ago we asked associates to conduct the analysis that's being presented here today. And I just want to make a couple of quick points about the analysis before I turn the conversation over to Deborah. First, it really is grounded in a historical perspective. It builds on an earlier analysis that Deborah and others conducted more than 10 years ago. It looks at these issues specifically through the lens of the Affordable Care Act, because that is the moment in time that we inhabit right now. And it was informed by considerable stakeholder input. And I know that a number of you in this room participated in focus groups or conversations with Deborah and her colleagues, either in the meetings that she held with policy staff, state policy staff, the meetings she held with consumer advocates, and the meetings that she held with representatives of the health insurance industry. So I want to thank you for that. I want to ground this in the perspective of the process that she went through. And I want to get out of the way and let Deborah take the stand.
Well, thanks, Marian. Good afternoon, everyone. I see a lot of familiar faces, and thank you all for coming. I really appreciate you being here. This is sometimes kind of a wonky exercise, and those of you who know me know I live very happily in wonky land, but I'll try to make it, interesting and to give you some of the highlights so that you can have some good takeaways today. So first of all, let me thank the California Healthcare Foundation for giving us this great opportunity to do this research, to take the time to really do the analysis, to meet with all the folks. It's just an incredible opportunity for a policy wonk like me too, and Brent and my colleagues on the project to really have this chance to do this kind of thorough analysis. I'd like to thank Brent Barnhart, who's here in the front, many of you know, and Margaret Ballou, whom I saw just come in, there she is, who worked with me on the project. Thank you very much to both of them. Very wonderful colleagues and very helpful to me. I'd also like to thank both the Department of Managed Healthcare and the Department of Insurance, which provided significant feedback and input to us during the project, and we couldn't really have done it without them. So thank you to all of you who helped with that. So as Marian said, we'll have some time just to ask me questions, and so I'm going to go ahead and jump right in. Let me tell you, we'll be talking today a little bit, just an overview of the Federal Affordable Care Act, which I'll now be calling the ACA going forward. We'll talk about how health reform can be a catalyst for change in our regulatory system that maybe hasn't been there before. We'll talk about what the California context is for health reform implementation. And then we will lay out for you some potential criteria that you can start with, add to, kick around, think about for how you would evaluate the reform options. And finally, we'll suggest some options for reform, again, to jumpstart a conversation among all of us as to what the possibilities might be. So, as Marian said, there is information both in the first report that I was fortunate to be a partner with Deborah Roth, whom many of you know, in 2001. And I'm really grateful to her for including me in that process. And so there's history in that report, and there's also history here. It turns out that you really can't tell this story unless you have that grounding in the history, so at least from my perspective. So essentially, where we are today really started by some early legal distinctions that were made in court cases and other things. I won't belabor here. So we started with kind of fundamentally different statutory frameworks, and we've been pushing forward through them all along. So over time, as we moved from traditional indemnity insurance to more and more of a managed care approach, we saw increasing standards and regulatory authority primarily placed on managed care plans, for sure HMOs, but to some extent PPOs. So then in 2000, the legislature created the new Department of Managed Healthcare and moved regulation out of the Department of Corporations and for the first time created a standalone state agency that was entirely focused on regulating healthcare. So over time, what's happened, even though there were some legal distinctions at one point, we've really seen kind of a blurring of those distinctions. So for example, PPOs were allowed under the insurance code in the 80s, whereas before that wasn't permissible. We have some PPOs that are regulated under the Department of Managed Healthcare, sort of making that hard to sort of figure out why one might be one place and not the other. And the other thing is the products have become more and more similar in this way. So for example, in the early days of HMOs, we had like the $5 copays. Those of us can sort of remember back. And it was more of a fixed copayment amount. And then over time, as the products have changed, we have seen the cost sharing go up. We've also seen it change. So you might now today see an HMO with a percentage payment instead of a fixed rate. So again, the products start looking more and more similar and as we go forward. And the other thing that's happened is, for some time now, I think really, starting with the Department of Managed Healthcare being created, our statutory activity has pretty much included both the insurance code, which regulates plans under the insurance code, and the Knox-Keene Act, or the Health and Safety Code that DMHC administers. So increasingly, we have parallel provisions in both. So just, for a little additional context, we have this data that shows that essentially the Department of Managed Healthcare regulates more than 21 million Californians, and CDI regulates more than 2 million. However, they regulate, to some extent, very different parts of the market. So this slide shows that CDI has significant products it regulates in all the markets, individual, small group, and large. And CDI has the bulk of the products it regulates in the small business and individual market. And you'll see that it has evolved to be true that the higher percentage of individual market products is now currently regulated by the Department of Insurance. So now we're going to switch to this entirely new paradigm, which I know we're all of the folks in this room are doing the work part of this, but as I was getting ready to speak today, I really wanted to reflect what an exciting time this is. It's not just hard, it's exciting. So this is the excitement. By 2014, we may see that 96% of documented Californians, non-elderly residents, will have some form of public or private coverage. Really quite amazing, and something most of us in this room have been working for in one way or another. So what is this new federal law? I'm going to skip through this. I'm sure you could make this presentation, and it could go a lot deeper. But I just want to highlight, so we have the coverage reforms. We have the health insurance exchanges, which will offer coverage to individuals and small employers in a new forum intended to help them be able to understand their choices better. And then we have a series of health insurance reforms that apply to carriers. And it's really quite interesting. You'll see in the full report, we have just one text box that has what the qualified health plans will have to do in the exchange. And it even kind of surprised me, really, how long of a list that really is. So in addition to the things mentioned here, I just want to flag that there's delivery system reforms that will be important for our discussion here, such as accountable care organizations, quality reporting, and the interplay between regulation and the exchange. So what this really is, this new law, is really it's a shift in the role of the federal government. Up until now, the federal government hasn't really played a significant role in health insurance regulation, and now we have new federal standards as well as some federal enforcement. But states continue to have a central role, and one of the things we did in the report, which was really an interesting exercise, is to look at two different things that are currently in law, just to see how very different it is, issue by issue, what the states are asked to do. So you look at medical loss ratio, for example. That is a federal standard, federally enforced, basically. And the states can have more stringent standards. They can ask for a waiver. The Department of Health and Human Services can look to the states to see if what the carrier submitted was valid data. But basically, it's a federal responsibility that in the rule they say, as the states and the feds get more experience, states will have a stronger role. Okay, so then we have premium rate review, which is very different. That is a state obligation with the Fed setting an initial rate of 10% for rates to be reviewed, but then saying there will be state-specific thresholds and giving to the states all of the responsibility to figure out what the process is with some minimum federal criteria that they'll look at. And then also saying, here's how we would define unreasonable, unjustified, or excessive rate increases, but that's just when we're reviewing it. The states can decide when they're reviewing it. And so you see that very different role just in these two issues. And I really think it's true as we go forward that we're going to see the need to really carefully look at each requirement, each area, and see now what is the state doing here, what's the role of the feds, and ultimately the role of the exchange. So what we try to do is to highlight some of the goals in the ACA as a way to think about where are we supposed to be going. So these are the ones we highlighted, and I think given the nature of that law, you could probably make a really long list. But so consumer choice. So the ACA is about transparency. It's about ease of comparison. It's about informed consumer choice. And so one of the concerns for us would be, as a state, is if we have different interpretations between two regulators, that whole ease of comparison thing that the ACA envisions could be potentially problematic. It's about consumer protection. So we have, limits on rescission. We have rate review. We have mandatory external review, a whole series of consumer protections. And so for us, one thing to look at is if I and my next door neighbor bought a PPO product, but her PPO product was under DMHC and my PPO product was under CDI, as we sat around the dinner table month to month, our experiences of who we could call, when we could call, what was covered, how it was determined, who decided how many providers I had access to, all of that would be different solely based on the department that regulated the product, not based on the product per se. So another big ACA-related change is this whole notion of product compatibility. I know those of us who've been around, and we have been around this issue a long time, we worried along the way that we would put certain whole product lines would not be able to be offered under certain scenarios. So if we, for example, brought all the products from Department of Insurance to managed health care, they'd have to meet our basic benefits in the Knox-Keene Act, and they might not have the same options that would be available to consumers. That was a real, legitimate concern that all of us have had over the years. Well, now what we have is the ACA trying to kind of, not completely, but to a large extent, narrowing that gap. Setting federal minimum standards for benefits, limiting lifetime limits, annual limits, a lot of changes so that over time what you see is these products getting more and more similar. Another goal of the ACA is efficiency. The idea that 8 companies cover 93% of the lives under Department of Insurance, and also have products under DMHC means 93% of Californians are paying the cost of dual regulation. Fair competition. So if they have different rules, the competition may not be as fair. Risk spreading is another thing that the ACA tries to eliminate or reduce. And then finally, this idea of the robust exchange marketplace, which is a huge and a wonderful, exciting opportunity for all of us. So what's our California context? So we have 2 regulators. They have different legal frameworks, different areas of regulatory emphasis. We've had mixed success. We do identical statutes quite often. Doesn't always come out identical. We have tried to require coordination, joint regulations. There's been really a lot of activity on this, trying to really make things as consistent as possible. And each of the departments brings something different to the table, relative strengths and weaknesses that we can all benefit from as we go forward. And to be fair, depending on the time period, the issue, the staff, the leadership, there's a lot of activity between the 2 departments all the time, as there is right now, to try to coordinate, to try to be consistent. That's happening all the time. So let me just give one example. The report lays out some comparisons between the two on some key measures. But so one example that's kind of relevant to the ACA is the whole consumer complaint process. So under DMHC, the plans are required to have an internal grievance process, which is specified in some detail in statute, unless it's urgent or if it's IMR care related. The consumer must go to the plan first, unless it's urgent, and then the plan, if after 30 days they're not satisfied, they can go to DMHC, which then has to get back to them within 30 days. Under CDI, there is actually no requirement in the insurance code for a grievance process. There's a robust statute that applies to all insurance around a claims appeals process. And the IMR, the Independent Medical Review Statute, mentions a grievance process, but that's the only time the word is used. And they can go to the CDI without going to the plan first, but then CDI typically requires the complaints to be in writing and has no time period by which they must respond. They just must tell the consumer within 30 days of a decision. So, you know, really different processes for me and my neighbor. So let's think about what the goals for regulation might be in light of all of what I've just said. So for me and for my colleagues working on the project, and I think for all of us, the most important thing should be the consumer's experience. You know, how can we make sure that the goals of the ACA and in our state law, which is robust in this area, are as closely achieved as possible? So what can we do about transparency and accountability? To me, this is critical. We cannot do all of what we're contemplating, plus everything we've already been doing, if we don't know what's happening, who's doing it, when are they doing it, what are the regulators doing. We have to have some accountability. We need to have consistent interpretation. We need to look at the costs and savings as we evaluate options. And again, as I said, build on the strengths of the two departments. So what are the options? We came up with two. There's essentially the option of one regulator, which, you know, really, if we were asked to implement the ACA in a vacuum, had nothing, pretty sure we wouldn't all sit around and say, I know, let's create two different departments and see how they come out with this, you know, so we wouldn't do that. So clearly the one regulator option is most likely to maximize efficiency, effectiveness, and uniformity. So in the report, we look at some of the relative strengths of each of our current regulators. The second option is if we are not in a place where we can do that, is we then need to spend some time, we think, on what can you do? What are the things you can do to bring us closer together in terms of the consistency and the expectations and the consumer experience? So we, again, suggest some of those. So the relative advantages of DMHC would be, and these, again, are specifically with the lens of the ACA. So the DMHC has already been implementing many kinds of activities and enforcing different requirements around minimum benefits, access to care, quality monitoring, oversight of integrated systems, so things very much like the accountable care organizations we're hearing so much about. They have that expertise on managed care and integrated delivery systems. It is a standalone state agency focused on healthcare. It has, since its 2000 inception, had very specific statutory mandates for consumer education, protection, and transparency, with related structures like the HMO Help Center, and is now the lead agency in the Federal Consumer Assistance Program. A position of the department inside the state administration creates opportunities for collaboration being part of the administration's team on healthcare reform. So in terms of the relative strengths of the Department of Insurance, so the CDI has significant experience on the ACA issues that are going to revolve around actuarial and legal expertise, things like premium rate review, medical loss ratio, the setting of the actuarial value of market products. It has expertise in rate review and rate regulation that's compatible with a lot of the ACA reforms. CDI is the state's voting member of the National Association of Insurance Commissioners, which provides it with the opportunity to both have input and to get information from that body. And it also has, through those relationships, the opportunity to work with the national carriers that it regulates and get information that's coordinated with other states. And then it also has the role as the licensor and of agents and brokers, which could be an early warning system for the commissioner about troublesome market trends. So those are the two departments, and believe me, there's, we say many times in the report, there's a lot more that would need to be done that is appropriate to do to think through the various ins and outs of this. So we're not even suggesting that we've covered that. We've just really scratched the surface. So what if we did this now? I think it's reasonable to be concerned as we're implementing the ACA what the impact would be. So we suggest some mitigation strategies which would include possibly phasing anything in. So let's talk briefly about institutional consistency option 2. And so again, we tried to think about some things that could help us all as a starting list of how we might get the two departments both the authority, the opportunity, and the encouragement to find additional and new ways to continue to work together. So one is that you just really require it. You can't have different regulations. If you have different regulations, tell us why. Explain what the rationale for your difference is. There is an existing joint senior level working group which was enacted 2005, and we could reinvigorate. It still exists, but we could reinvigorate that and had some additional reporting and requirements that give us all an opportunity to see what they're doing. And you know, there's a lot here about that I mentioned earlier. Regular reporting, posting, being able to really see what the two departments are doing and to be able to do effective legislative oversight and evaluate what they're doing. So we could realign the statutes and regulations, and that can happen as we're doing a lot of the work we're doing already. I know many of you are working on bills moving through the legislature. And finally, there's this idea that we could look at, since there are different strengths in the two regulators, is there some way to take advantage of that by, for example, having the Department of Managed Healthcare take responsibility for looking at the provider networks of all the plans that are trying to be qualified health plans in the exchange, for example. Or having the Department of Insurance look at the actuarial value of the products that has to happen in our state because they have that expertise. So looking at how do you rely on the different expertise of the two departments. So I know my time is running short, so I just want to reiterate and remind you that we know that there's a lot more analysis and review that is needed, and that our goal is really to jumpstart the conversation. And you know, my conclusion as a researcher is, although as a person who's worked in this field for a long time, I've had the job that many of you have, trying to sift through issue by issue, bill by bill, whatever it is, trying to figure out, well, what does CDI require? And we get in the terminology problems. Oh, that term doesn't actually work in the insurance code. And many of you have made your careers, really, on being experts in that. And, you know, that's... yeah, not me. So you know, I think it's really striking to me, as somebody who's been totally aware that it would have been good to do something about this before now, when I put the lens of the ACA on this, to me, it was so compelling. Like, it is time. So I really want to, you know, open up to all of you that opportunity to engage in this conversation. It's a tough conversation, but it's so important, and the ACA really makes that point. And it's really an opportunity. I really see it that way, but it's also an imperative, I think. And you know, I hope that when if you have the chance to read the full report, you'll see the things we saw as we looked at this and really, you know, were just so convinced that it's really the time we need to engage in this conversation. So thank you for your attention and even laughing at my fatal jokes. And so I'll answer questions now if anybody has. Yeah? Yeah. So the questions at this point, we hope, are mostly clarifying ones, if you had any, and then there will be opportunity for some additional discussion later. So I've overwhelmed them.
Crystal clear. So let me invite our, thank you so much, Deborah. Let me invite our reactors to come on up. and we will get them settled. I think we might need mics for, did we get everybody mic'd? Anthony and Patrick, did you get there? I think we might need sound stuff, but it's okay. We're going to start with the people who have mics on. And I should have said earlier that there are bios for all these folks in your packets as well. I didn't give Deborah the glowing overview introduction because I think she is well known to you, but everybody here really brings just a wealth of experience from a variety of roles, really, to this conversation. And we have with us today, and we're going to take them, their remarks in the order that are listed. We have with us Maureen McKinnon of the California Department of Managed Health Care, Janice Rocco of the Department of Insurance, Pat Johnston of the California Association of Health Plans, and Anthony Wright of Health Access. And we know they're all going to come at this from a slightly different approach, but I know from the conversations we've had that they have all thought a lot about this. So, Maureen, great. It's up to you.
Is my mic on?
Oh, yeah, I think it is.
Okay. All right.
Okay. So, can I, I'm sorry.
Sure.
Very, very sorry. Just one last thing. What I asked our reactors to talk about was, their thoughts about where things stand today, what opportunities the ACA brings, and just then any advice or perspectives they have on where to go from here. So that's really, I hope, the nature of most of the remarks we'll hear.
Great. Thank you for the opportunity for the Department of Managed Healthcare to comment on the report. We appreciate the opportunity to talk about this well-written report. It is very thorough, complete, and informative. It really details the history and the rationale of California's current dual regulatory structure. The DMHC is very proud of our history of consumer protection and role in stabilizing the financial stability of the delegated model delivery system. Over the past 10 years, we've built an organization based on everyday passion to protect the rights of consumers. We've gained expertise in the licensure requirements under the current law and provided vigorous enforcement of the legal obligations and responsibility of health plans. We have also strived to provide predictability in the managed care delivery system to achieve maximum transparency and efficiency for consumers, for providers, for medical groups, and for health plans. We understand regulators, we should constantly strive to improve the level of service provided to the public. To that end, this report makes a lot of good points regarding what is working, what is not working, and opportunities that we can all do better. Consolidation could have significant advantages in terms of clarity for consumers, clarity for those that are regulated, increase the efficiency of the regulatory processes, provide consistent implementation and interpretation of the federally mandated changes, and avoid the risk of insurers taking inappropriate advantage of the differences between the true regulators. With the changes brought by the Affordable Care Act, signs are pointing to the increased importance of a Knox-Keene type of product with comprehensive benefits being more relevant in the ACA world. As California moves forward in implementing the ACA, I'd like to provide some comment on the department's evaluation of the criteria in Deborah's report for policymakers to contemplate if changes to the current regulatory structure are proposed. I think the department agrees with Deborah that one of the most, if not the most important criteria to consider in evaluating regulatory reform is improving the experience for the consumer. The process of buying and getting affordable health insurance and obtaining help with health coverage questions, it needs to be simpler, it needs to be more accessible for consumers. It should be easier for consumers to understand what the coverage choices are, how to access care, how to navigate this complex healthcare system. Another important criterion to consider in evaluating the options is what can be done to trim government to ensure more efficiency through streamlining administrative requirements and eliminating outdated or duplicative requirements without sacrificing consumer protections. The report also stresses the need for consistency and collaboration between the two regulators, whether changes are eventually proposed or not. DMHC and the California Department of Insurance have collaborated for many years on many different issues. This has really increased dramatically since the ACA, and I would say really in the last 6 months to a year. We communicate on a very regular basis and really strive to be consistent in our interpretation of the ACA and of California legislation. I think it is really safe to say that both of our departments are fully committed to an ever-increasing level of cooperation and consistency in the future, and this report gives some good examples on how this can be achieved. As we move forward in continuing to implement the ACA, we welcome this report as a very good starting point for succinctly laying out the different issues for discussion by policymakers. As you know, there are many policy questions and implications that need to be considered in the future, which will be best addressed by the administration and the legislature as we strive to provide health care to as many people as possible. Thank you very much.
Janice.
Great. I'd like to also thank the California Healthcare Foundation for inviting us here, and Deborah Kelch and the others who worked on this report. I think it's very helpful to start this discussion. There have been questions for many years about why California has 2 regulators of health insurance and health plans. We're the only state in the nation with this bifurcated system, and this topic was the subject of at least 2 reports in 2001, and now this week is the subject of 2 different reports. The purpose of the California Healthcare Foundation's report is to jumpstart a conversation with all the stakeholders, and given all the stakeholders in this room and the folks on the phone, I certainly think that that conversation will be beginning again. The Affordable Care Act presents a great opportunity to significantly increase the number of Californians with health insurance coverage. In order to meet the goal of expanding coverage to millions of Californians who lack health insurance coverage, clearly we need to work to educate the public about the changes in the law, to let them know what their coverage options are, what we're doing to make products more affordable, and what they need to do if they need help resolving a dispute with their insurance carrier. 2 provisions of the Affordable Care Act that this report highlights are the medical loss ratio requirement in the federal law and the new rate review requirements. The Department of Insurance has taken swift action to implement these provisions. When Commissioner Jones took office less than 6 months ago, he made clear that implementing the Federal Affordable Care Act was a top priority for him. To that end, on his first day in office, he signed an emergency regulation that now gives him the authority to enforce the 80% medical loss ratio in the individual market. And that very same week, he asked the 4 major health insurance carriers in the state with pending rate filings before the department to postpone implementation of those rate increases for 60 days while the department had a chance to review them. After our actuaries reviewed the rate filings, 2 of the carriers reduced the rates before they went into effect, and another withdrew the rate increase entirely. And during the months of January and February, Commissioner Jones spent a good deal of time trying to help educate the public about some of the new provisions in the Affordable Care Act that were going into effect January 1st, including the state and federal version of the prohibition on excluding children with pre-existing coverage from the health insurance market. Successful implementation of the Affordable Care Act is going to take a lot of public education and outreach, and Commissioner Jones will continue making this a priority. In order to expand coverage, you need to have affordable products. The ACA has new rate review requirements, and given California's very limited authority when it comes to regulating rates, the Department of Insurance has been quite successful in getting insurance carriers to lower their rates so far. That may be because Commissioner Jones is the sponsor of AB 52, the bill that would give both the insurance commissioner and the director of the Department of Managed Health Care the authority to reject excessive rate hikes. Many ask, how well is California's bifurcated health insurance system working? And we can talk about positives and we can talk about some of the challenges. In terms of coordination and communication, the 2 departments, as Maureen said, are working very closely together. And though there are some times where we have inconsistent outcomes, there are many times when the result of working closely together means that we do have consistent outcomes, and that's certainly helpful to both the consumers and the insurers. We've been very effective in our almost 6 months so far implementing the provisions of the Affordable Care Act since the Commissioner took office. We've had good outcomes for consumers, despite the bifurcated system when it comes to rate review, claims handling, enforcement actions. The Department of Insurance also has a whistleblower provision in law, key TAM actions we can take. Some of you may have read about the cases that we've intervened in having to do with Bristol-Myers Squibb and with the Sutter Hospital system where there are allegations of provider fraud. Some of the drawbacks of maintaining the status quo are, as have been discussed, the risk of inconsistency, confusion for consumers. I had a few difficult calls with consumers after one of the rate increases that we were able to get reduced, where they just couldn't understand why they weren't getting the rate reduction that had been announced in the newspaper. But with two regulators, you sometimes have different outcomes with the carriers. As the Affordable Care Act implementation continues with the announcement of the Essential Benefits Package and removal of lifetime and annual caps, the need to educate consumers, resolve their complaints and problems, and to prevent confusion, an increased need for scrutiny of insurer solvency as carriers compete for market share. We cannot afford to allow insurers to choose over time to place their products with the regulator they view as the most favorable to their business or policy interests. The ACA presents new opportunities and challenges. We look forward to the opportunity to work on these issues and look forward to the legislature and governor making decisions about how to handle them.
Thank you, Janice. Pat?
Thanks very much. The Foundation sponsored this report as part of its continuing commitment to implement the Accountable Care Act in California. The California Association of Health Plans, representing 39 full-service managed healthcare plans, including for-profit, not-for-profit, and public agency plans that deliver care particularly to Medi-Cal and to healthy family citizens in our state, share that principle and share that goal of implementation. Many health plans have affiliate insurance companies and know that differences in the Knox-Keene Act and the insurance code and differences in plan design and delivery system mean that there must be differences in regulation. So the report focuses on regulatory aspects of the state's efforts to implement the ACA, and I just wanted to make 4 points. First, California's current healthcare system and the ACA have much in common. Secondly, different products account for different regulation. That's been the history. That's still the case. There are higher priorities for implementing the ACA in California, things that have to be done by 2014 and beyond, than figuring out whether DMHC and CDI ought to be merged. Not that it's not an issue, but there are key concerns to make sure that coverage is extended, and those ought to be addressed in the first priority. Lastly, better coordination among these regulators and other state agencies ought to be coordinated by California's own Health and Human Services Agency. So first, with respect to ACA and California, we've had an emphasis on managed care. That's why a separate regulator was established in order to deal with the HMO model, which is far more extensive in California than in any other state. And so the Congress and the President sought to look to managed care as the principal model to deliver health care in the future. And the emphasis on the accountable care organization concept, beginning with Medicare, is evidence that the Congress and the President want to go through better coordinated care. And while it will likely have some impact in California, in many ways the ACO model is a way for the President and the Congress to draw attention to other states the benefits of managing care rather than relying on fee-for-service. Secondly, the ACA emphasizes comprehensive benefits. As has been referenced, The Knox-Keene Act provides that basic health care benefit package. It's extensive, and in addition, the legislature, in its wisdom, has seen fit to add over 40 specific other mandated benefits. And so, as Deborah mentioned, the federal government soon, we hope, will identify those essential benefits that have to be part of a health insurance plan in California and elsewhere in the country. So we have that rich benefit package here in California to a much greater extent than other states. Also, consumer protections were emphasized at the ACA passage. And DMHC, as has been mentioned, has an internal grievance system. It operates a help center. The independent medical review was a trend-setting effect in California, which many other states don't have, don't understand, don't like. We've had it for a decade. And we have the Office of Patient Advocate, which also is an educational tool and a resource for consumers. The report is well written and clear in showing the history and explaining the differences between traditional health insurance, which is a promise to pay claims, and managed health plans, which are a promise to deliver care. And so those distinctions have changed, as Deborah indicated, over time. There have been some mutations, particularly in PPO, but there is essentially different models that still persist. HMO plans rely on delegated payments to medical groups who quarterback the care of enrollees with a broad array of covered services and an extensive network of providers, and usually, not always, with modest copayments. PPO plans reimburse network providers that treat insureds for services that may be more limited and may have higher deductibles and copay than the HMO plans. Most Californians, as the evidence shows from the group and even the individual market, most Californians are in managed care plans regulated by DMHC, which was really invented to deal with these integrated delivery systems. But those who choose indemnity plans through the California Department of Insurance may do so because they get direct access to specialists, or they're willing to forego certain benefits or pay more out of pocket, copays and deductibles, in order to reduce premium. So that's been a consumer choice. The report's example of the timely access law and regulations shows the difference that the product makes. CDI enforces a geographic proximity for providers, which may be sufficient for the flexibility that a consumer wants in a PPO. DMHC requires a time-elapsed standard to assure much more fully access to care. So they are different standards, but they reach to the same legislated goal, which is seeing doctors, and they do so differently because the products are differently. It's not to say they couldn't be merged or changed, but it's a rational basis for one department going in one direction that's slightly different from the other department. Third point is, going forward, the state has much to do to implement the ACA by 2014. The new rate review is being implemented by both departments. That's SB 1163 by Senator Leno of last year, and some of the references to rate discussions or rate changes are under the auspices of that authority of that law. The exchange is getting organized. Perhaps the most significant passage of legislation last year to implement the ACA, and perhaps the most important thing that we need to do in the state of California to reach that goal of extending coverage. Market rules are changing, including the end of medical underwriting and the beginning of guarantee issue. The federal government, as we said, must decide essential benefits. And Medi-Cal must prepare for substantial expansion of its numbers with a challenge that we all face in the state of California of an adequate network of providers in this state, a network of providers which tightens every time the legislature passes another budget. So all of this has to go forward by 2014. All these jobs really take precedence over whether or not to merge two departments. Lastly, and what our job in part was to do, was to reflect on the standards in a discussion going forward, because even though there are more important things to do to get ACA fully implemented in California, that doesn't preclude all of us and lots of others from discussing the appropriate regulation and what ought to happen in the future. So what are those standards in addition to those that are indicated in the report? One would be successful coordination with the exchange so that the exchange can rely on DMHC and CDI for information on solvency and to assure consumer protection. So the exchange has a lot of jobs, but it doesn't need to be a duplicate regulator along with the two we have. Nevertheless, the important information and jobs that both departments do now can provide terrific information for the exchange to make its judgments about quality of care and qualified health plans in order to make sure that ACA is fully implemented. The other point, which I mentioned briefly, is that Health and Human Services already coordinates Medi-Cal, Healthy Families, Public Health, and should really, whether formally or informally, really provide some oversight and continuity and transparency and information over all of the regulatory aspects that are part of implementing the Accountable Care Act. And that would include the kinds of judgments, decisions, and impacts that DMHC and CDI have. The Secretary of Health and Human Services is positioned to look at that. And while most are in the executive branch already, and I recognize that, that CDI is not, certainly the collaboration and cooperation that's evidenced itself in the two agencies' history and is reflected in the comments already today ought to signal that that can be done and done effectively. Lastly, the development of data, which is referenced in the report, and more information is very good and will help in this continuing analysis that's called for, because in a way the consumers have the important votes here. As the ACA is established, as the exchange offers a range of benefit products, consumers will make choices about that. And we will learn whether we have an expansion or a contraction along the PPO line or along the HMO line. And that information will help, I think, inform policymakers, many of whom are in this room, and advisors to policymakers and stakeholders as to what's the appropriate regulation and regulatory framework based on what our experience is in how people access health care in California through the exchange. Thank you.
So good afternoon. My name is Anthony Wright. I'm the Executive Director of Health Access California, the statewide healthcare consumer advocacy coalition. I'm pleased to be here, and I thank the foundation for inviting me, and pleased to be with the esteemed panel. The report states that there are few defenders of California's two-regulator system, and we don't quarrel with that assessment. That we have long supported a unified regulator. It doesn't make sense for consumers to have two regulators, both from the point of view of a complaint process. Who do you go to complain to if you have a problem with your health insurer? It doesn't make sense from public accountability point of view in terms of if there's a problem in the system, who is accountable for that issue. It doesn't make sense from an insurer point of view in terms of the ability of insurers to choose their own regulators. That being said, there's a lot about our healthcare system that's indefensible. You know, that's why we have health reform. I mean, we're justifiably proud in California that there's a lot of areas where we are actually in the lead. We passed in some cases first in the nation laws and regulations and protections on everything from independent medical review to timely access to language access to other key issues that we're rightly proud of. But in other areas, we're the wild, wild west. The insurance market is there's not as much oversight, and I don't put that on our regulators. I put that there, you know, in terms of our regulatory structure. And that was actually part of the reason why that instigated both the efforts for health reform here in California and what eventually became the federal law. And so really, from our point of view, our primary focus has to be consumer protection, and with it, the best implementation of the Affordable Care Act in California. And I think that that's important not only for Californians, but for nationally, because I think California, as big and important a state as we are, doing this really well is really important for its national success. So, and it is remarkable how much work that we have to do. I mean, we've had just legislatively, in terms of aligning our statutes, you know, we had a variety of bills last year that were passed with regard to whether it be rescissions or with regard to caps on coverage or other rate review and other issues. This year, there are bills in the legislature that further work to align in areas like the medical loss ratio that Senator Alquist is working on, or on small business, on the small group market of which Assemblyman Monning is working on. Next year, we'll probably have to take on the individual market and those rules. So you know, there's a lot of just specific technical work of how do we get the insurance code and the health and safety code and move them up. But I think that's not even the fundamental. Actually, I mean, that's important. But it's as much important that we get not just the letter of the law, but the spirit of the law in place. In terms of, you know, if we get to 2014, it's not enough that we get to guaranteed issue. We actually want to move the way the insurance market works so that insurers no longer compete on the basis of risk selection, on the basis of who can have the healthier population and who can avoid the most sick people, and actually move to a world where they actually compete on cost and quality and customer service and comprehensiveness. And you know, that's going to take a very active oversight, an active stewardship of the market, beyond just sort of an alignment with the words in statute. And so I think that's the challenge. We also have to manage this transition to make sure it's phased in. You know, I worry that some of Pat's members will use this period between now and 2014 to game the market before some of the new reforms come into place. And so we need vigilance by our regulators. And so then the question is, in this activity, is this a time where if we're reshuffling the deck, we might as well throw the merger and consolidation of the regulators in with that whole mix? Or is there another way to phase this approach in to make sense of the priorities that we have to look at moving forward? This is, I think, regardless, that in terms of all the tasks that we have to do with regard to align with the Affordable Care Act, we should make sure that in every case, whether it is with regard to having a robust consumer complaint process, or whether it is aligning with certain consumer protections, it should be in the stated policy of California that we are moving toward alignment. That we are so that if it doesn't happen in the next year, in the next 2 years, that we are getting to a place where it will be better aligned. I think the big usefulness of this report is that it goes beyond sort of the governance question that has long sort of dominated this issue. Most of the time when we talk about this issue, we talk about it from a DMHC, DOI dialectic. And that's, you know, it's interesting, there are personalities involved, it's political, but in fact, what I think what is useful about the report is how it details all the other things that have to happen that are actually separate from the governance issue to alignment. And so I think that if anything, not only does it detail all that work, but it also gives us a roadmap of how we can actually start to align all those other areas, whether it's on consumer complaints, whether it's regard to benefit standards, whether it's regard to specific actions, so that we can get to a place where there is consistency for consumers and alignment. And I mean, and if there is this transition period where we are getting to alignment as we implement the ACA, you know, I mean, I think of it sort of like as I drive my Toyota Prius, which is a hybrid and it has both an electric source and a gas source, and I don't necessarily know at any particular time what part is driving that car, but I don't need to know, and most consumers don't need to know, but actually it's good that it's transparent, that I can look at my dial and see, like, oh, I'm running on the battery now. But the point is that I think that it's really important that it be seamless for consumers, but that it also be transparent, even if it is inelegant from an engineer's point of view. I know lots of engineers who hate hybrids because it's just, why do you have these two things in your car? But I think the point is that we need to be focused on the consumer experience and consumer protection. So at the end of the day, we want a consolidation that just takes the best of both. We can imagine a consolidation that would actually do the reverse, and that's not what we would be for. But we think there's an opportunity to get the best of both, and in fact to go beyond there, because that's actually in fact what the Affordable Care Act requires. And so let's keep focused on the many opportunities of the Affordable Care Act, and one of those opportunities is to get better alignment with regard to our regulatory structure to the benefit of California consumers.
Thanks, Ed. I'm going to invite Deborah to come back up and thank all speakers again, who I think did a great job and indeed worked in advance to synthesize the report in order to provide these remarks. So I do really appreciate your being with us and offering your perspectives. And we do indeed have about the expected amount of time for questions. So I would invite anybody who has a question for Deborah or for the panelists, or you know, a provocative issue you want to hear some reactions on, to raise it. The mics are in the front. We seem to have two right next to each other, I think because of our dual recording approach here. Everyone's shy. Please come up, and if you would please identify yourself, we'd appreciate it. People are maybe just so wedged in they couldn't get out of their seats if they wanted to.
Dan Carson with the LAO. So I'll ask Deborah to react to the reactors, but in particular, the issue that Pat raised about when is the timing right to do this, because there is the question of, you've got between now and 2014, you could argue that's a window to get where you need to go. You could also argue it's a distraction from where you need to go. So I'd be curious on your sense of that.
Well, thanks, Dan, and thanks to all the panelists. I think it's a really good point. It's raised in the report as well. It's a legitimate concern. How much can we take on and where? I would say two things. I think as a matter of natural course, which is kind of what, Anthony, I think you highlighted, we are already going to be sitting these statutes side by side, trying to align them with the federal law. So why not really put our energy and attention on that as we do, to make sure that we're really thinking about, so identical words is not enough. That's kind of the point. And while the two departments are going to collaborate, good, reasonable, detailed discussions about what will this look like given the rest of your statute and regulatory process, these identical words that may match the federal law specifically. So that's one thing I would say, is that it's going to be part of the natural process. We have to grapple with it as we have always, and it's a huge opportunity to be thinking about this and to put our attention on how will it really come out. If we put the same list of benefits in both codes, will consumers get the same coverage? Yes or no? If we don't make other changes, no. So I'm just saying those are the opportunities that will just happen. The second thing, I guess I would say, I can't really make the argument that you have to do consolidation at this moment and you have to do it before 2014. I can say if we don't think about it, the job of the exchange will be that much more difficult. And it's that other level of putting everything side by side and then figuring out, in addition to all of this, what do we want our qualified health plans to do and be, and how do we want them to comply? So I guess I feel like if we get to 2014 and we've just been implementing the federal law, doing the same statutes, and we're not really putting a lot of time and attention on this, we will have pulled ourselves farther apart instead of getting closer together. So that, I mean, I'm not going to try to suggest that you have to do it now, but if you don't pay attention to this, in my view, it will be a dramatic and a missed opportunity and a potentially huge challenge for the consumers and for everyone involved in what we do.
Okay, so people feel like they can raise your hand if you've got a question that you'd like to raise.
Hi, David Panish. Senator Johnston raised an interesting question about whether in the future we were likely to see more HMOs or more PPOs. And I'd be interested in what the panel thinks we're likely to see over the next couple of years as the ACA gets implemented.
So to clarify, David, your question is in the interim or in 2014 or both?
After the ACA is implemented. 2016.
Okay. You want to start, Pat?
Well, we don't know. I raise it because now you have a dominance of managed care, and it would seem that that's the emphasis in the ACA, but it remains to be seen whether PPO, more indemnity kind of arrangements with the essential benefits in the exchange have appeal or have appeal in, say, rural parts of California. So I think it's a fair question to ask, but we shouldn't prejudge the answer to that. But the coordinated care, which is what an ACO is designed to be, is what the President and the Congress wants us to do. So I think that richness of benefits and consumer protections indicate we're going to see more of that in California. But you know, the exchange is now full membership. Is that right, David?
As far as I know.
Right. So, you know, the exchange has so many jobs to do. And we talk about, you know, consumer access. No wrong door is a terrific concept, but it would be very hard to do technically and in practice because the outreach efforts that a lot of people have done to try and get signups for healthy families, or for that matter, eligible Medi-Cal, have shown that we miss people or they don't come forward. So the exchange job to, and us with them to educate will be large. And I just think as we figure out the regulator and whether over time the differences have narrowed or there's a direction indicated by what most everyone's doing, we will know, but we won't know immediately. So for instance, at CDI, where they regulate hundreds and hundreds or thousands of companies, right, property casualty and life insurance companies that are all over the country and have subsidiaries for disability insurance, part of which is health insurance, right? So that's a part of what's available and regulated and offered in the California market, principally to groups, but some to individuals. We really don't know, as the exchange and the Accountable Care Act's essential benefits is fully in place, whether those range of companies will still be in the market or want to be in the market. You know what I mean? So, but they may be. So I'm reluctant to prejudge that. As we look at all the other questions, I think good data is what we need.
And Deborah wanted to weigh in on this, and then Anthony.
Well, I'd say a couple things. First of all, this regulator question is not an HMO PPO question. And if we think of it that way, we'll miss some of the opportunities. We have PPOs under Department of Managed Healthcare, and they meet the same standards with very few exceptions that all the HMOs meet. So the access standards that apply to HMOs under the Knox-Keene Act also apply to PPO. So it's really important not to start thinking about it in terms of HMO PPO. To David's question, I don't think we know, but there's a few clues in the ACA about what is contemplated, and these questions around the delivery system structures and the accountable care organizations and those delivery system changes that are contemplated, about which the provider community is in major, whatever it is they're doing, trying to organize and reorganize and think about what they need to be. Any kind of transfer of risk between an insurer, a health plan, and a provider under California law would make them have to go to Knox-Keene. So I think we know a little bit about what's contemplated. I think Pat's absolutely correct. We don't know which companies will decide to offer which products. But I think either way, as long as we keep remembering that the really challenging part of this is HMO PPO is not the dividing line. It's PPO, HMO, Knox-Keene, or PPO, CDI. And so I think as long as we keep that difference in mind, it will help us think through, as the products change, what's really changing underneath. So is it the delivery system, which the ACA seems to want? So,
Anthony.
I mean, I would just say that there's two countervailing trends, both responding to the cost pressures. One is the market moving toward of employers and insurers shifting more cost onto risk and cost onto consumers, which was sort of the trend of that we found troublesome. I think the ACA tries to better steer those pressures toward more integrated, coordinated care solutions as a way to try to grapple with the issue of how to address cost and quality issues, and with regard to some of the things that Pat mentioned with regard to standardized benefits and providing better security for consumers, that in fact the system has a better opportunity to try to deal with some of these systemic changes than individual consumers have that lack market power. At the same time, I do think that because of that evolution, in the market, then whatever evolution that happens in the regulatory structure needs to have a specific health focus. I think we saw some really advantages when DMHC was taken out of the Department of Corporations and was a standalone patient protection health-focused entity. At the same time, I see that the Department of Insurance, I think has I think in just even the last year, I mean, Janice's position is the Deputy Commissioner for Health, because it's an elevation and a recognition that health has some very particular challenges and requires that specific focus. And so I do think that specific health focus is really important.
Janice.
Just to add, I mean, I agree with folks that we don't know for certain how things will play out. Deborah's report points out that HMO products and PPO products are more similar today than they were in the past. And I think that with the Affordable Care Act, that's going to become even more true with the essential benefits determination. The HMO products in California may change. Also with the deductible cap and the elimination of the lifetime and annual caps, that's going to change things. And so you may get to a time period where the products look so similar that it's about which doctor you get to access. And so we're not sure yet how it's all going to play out.
We have, let's start with, Karen, if you would, Beth, let's start with. And
Hi, I'm Beth Abbott from Health Access, and my question is for Maureen and Janice. I heard you both say sort of recount many of the successes and emphases of your respective organizations and what you have done that you're particularly proud of. I would be interested in your reaction. I'm kind of a meat and potatoes girl, so I would like to know what's your sense of some of the things that Deborah and her team suggested that were the specific recommendations, like reinvigorating the senior policy or consultation, I don't know quite what to call it, but some of the things that are, if we do not go to full combination of these two agencies in some fashion, if we did some of these things that would enforce consolidation and cooperation to an even greater extent, to what extent do you think those are feasible and would achieve the intended result that Deborah and her team and the foundation, all of us in the room would like to see? Thanks.
I'll go first, yes. I'm not sure if that needs to be done by statute. I can say that since the ACA, and particularly since January of this year, we communicate with CDI several times a week on various issues. So I think our communication and our attempts at consistency have been really strong this year. I think that will continue to be so. I think that we'll continue to try to do that. So I don't know if we need to have anything formally done, and just continue in our current communications status.
And just to add to that, I think in terms of the things that are in the report, I do think consistency is important. I do think that both of us would agree that the most important thing is improving consumer experience, and transparency is very important. In terms of formalizing things between the two departments, I don't know if the legislature is interested in that. That's certainly something that they can look at. But as Maureen said, we're working together pretty constantly, and not just Monday through Friday sometimes, or through business hours. So, there's certainly a close relationship that's working as well as it can when you have the departments both existing doing similar things.
Deborah, you just want to say a word?
Yeah. One of the things I think to think about in that whole area of activity, it may be certainly true that, and it is true, that the departments are really working closely together. I think one of the challenges is it's really behind the scenes. And so I think what we were trying to say about reinvigorating the joint senior level working group wasn't that people aren't talking to each other. It's just that if I or policymakers or anyone wants to see what they're doing, that's not as clear. So we laid out a couple of additional things we could do, but really being able to see where the collaboration is happening, what the differences are, transparent, through all the processes, looking at, what are the plans filing, sort of not just the end disposition. And, all of this would take time, work, and effort, but I think that's really sort of such a core value of the ACA, that anything we can think of that goes beyond behind-the-scenes collaboration and brings it up front, and then if you can't get there, then we all can work on, well, what's the challenge there, and really begin to have more information for making the policy choices that all of you work on every day.
Thanks. One last question, or no? Okay, we have it. Yes, one last question. Yay. Okay.
Andrea Rosen. I was very intrigued by Mr. Wright's observation that in order for healthcare reform to be successful in the long term, what's really going to be required is a paradigm shift in how health insurance or HMOs operate. And that may be a metric of getting out of the game of adverse risk selection and going more towards focusing on delivery of care should be used in evaluating whether or not the shift should, whether or not a consolidation should take place. I've not seen any evidence as a regulator, and in full disclosure, I do work for the Department of Insurance, but I've not seen or read any evidence that HMOs are not just as much in the game of avoiding adverse risk as insurers. And so I think it's a little bit of a stretch to say that the HMO model comes closer to at least the ideal view of an ACO and what it's supposed to be able to achieve in getting out of the game of avoiding risk and more in the game of being measured as a healthcare deliverer in terms of cost and quality. Keeping costs down and keeping quality up. That should be the metric, not how good are we at avoiding risk.
Sounds like more of a comment than a question, and I don't know that anybody would want to dispute it.
My question is I haven't read the report yet, Deborah, but is that a criteria that would be useful in using to evaluate whether to consolidate or not, and if so, how?
Well, first of all, you won't find in the report any suggestion that the model type of coverage has anything to do with how the carriers perform on risk selection. To me, there's no connection. And I would agree with you completely that that it's sort of the business model, really. It's the business model for all the plans in most states, but in California in particular. So that to me is not about, is it a PPO or an HMO? That I don't think that's really the issue. I think this question as to where the juncture lies between ACO's delivery system, the approach of the ACA, I think it's pretty clear. Full disclosure, I'm an appointed member of the Financial Solvency Standards Board of the DMHC, and that conversation there about ACOs juxtaposed to Knox-Keene in our current system suggests that basically what is contemplated at the federal law has been going on in California to some extent for a long time, primarily in the HMO delivery system in the delegated model. So that would be where the juncture lies, but I would put the risk selection separate. And I think it's true that the business model, pretty much really public, private, nonprofit, I think the business model has been to try to, whatever your mission is, try to not take care of the sickest people because they cost the most. I mean, I think it's a rational model in lots of ways.
Unsurprisingly, Pat and Anthony both would like to weigh in on this.
I mean, I think let me be clear. There's a lot that is new for both regulators in the new world. I mean, this is, the issue of, we really haven't had the experience of doing that kind of aggressive guarantee review and oversight over a guaranteed issue type market, and all that entails in California. With the limited exception of small group, which is different in its own ways. I think the whole issue of oversight over rates is a whole new world we really haven't had the set of the conversations and the negotiations over rates prior to the infamous Anthem Blue Cross 39% rate hike that where President Obama became our insurance commissioner for a moment there, and it was the federal and state implementing that created the tools, and I think we're starting to go into that world, and obviously that's going to be a new place. And then I think in terms of these benefits, and then there's some areas where we have some experience in one area as another. I think my main point was simply that it's not just about and it goes to Deborah's point that it's not just about even though the fact that insurance code and for years we've been trying to align. Whenever we've put forward a consumer protection, we try to include it in both the insurance code and the health and safety code. That's something that we try to do, but there's still so much that is different. But that's not the only thing. I think that it is also the spirit of what is the end goal we're trying to get at. We saw just this past year with the whole business of how do we cover children with pre-existing conditions in the market, that we required some active intervention to make it work in California, both make it work in terms of actual insurers actually offering the product, and make it work from the consumer point of view of actually making it so that it would actually provide an affordable choice for families rather than something that was theoretically accessible but priced out of the market. And so that requires sort of a level of engagement that I think that's a challenge for both regulators, and to the extent that there is alignment to do that, and to the extent that this can be used as a way to get to that that stewardship of the market, it's crucial for consumers.
So I'm going to let you have the last word, Pat, but I am conscious of time.
Yeah, just a footnote, and that is the mandate for people to purchase health insurance is a component of the ACA so that everyone contributes to the pool, and then all of us in differing amounts at different times are going to need health care. So you can have guaranteed issue without any pre-existing condition medical underwriting, but if you don't include everyone who can afford to buy insurance, and if they can't, the law provides through the exchange an ability to get subsidies, but if you don't, then you will have what some states like New York and New Jersey have experienced over the years, and that is you have guarantee issue, you have to sell it without pre-existing condition, and people with serious medical needs that are expensive buy it, and everyone else can wait until they need it. And so that's a recipe for high insurance rates. That's what they have. California went in a different direction, so you compete, but you have the underwriting. That's gone. That's gone. So that's good. The exchange will set up a fair marketplace. People can shop. Risk selection ought to be fairly analyzed, and certainly our departments can help with that with good data, and certainly the exchange will look at that very closely, and then if everyone does their part by purchasing insurance and people have a choice within the exchange, we ought to be able to get beyond the history that we've had, which is some people can never afford insurance.
Thank you. So clearly we've just begun the conversation. I want to ask you again to please provide us your comments through the form or through email. We are really interested in what you think ought to happen next, especially with respect to whether there's an ongoing conversation to be had. And I want to thank all of our speakers and ask you to join me in doing so, and all of you.